Good morning. Thank you very much for the opportunity to present today. My view will be much more founded in the locality, in our own challenges and our own achievements. So it's a little bit different aspect of what you have seen before. So where we are from newly established West-Northwest regional hospital group, previously known as Salta Hospital Group. We, as a hospital, we partner with the University of Galway, and our hospital group delivers the cancer care to almost 1 million of people. Obviously, within our hospital group, population is slower, but we are receiving referrals for some aspects of delivery of cancer care from the neighboring hospitals. We have more than 4,000 yearly cancer diagnoses in the region, and the cancer care is delivered within one center hospital, which is Galway, 2 other hospitals that have on-site hematology and oncology services, and 3 smaller hospitals, which are outreach hospitals. Our population, unfortunately, is known to be older than average in Ireland and is economically disadvantaged. One of our biggest challenges is actually the distance for the delivery of care, and some of our patients need to travel 3 to 4 hours one way to get to the hospital, get to the treatment center. So we were funded for the cancer trials just last year. We started our funding cycle in 2024. So we unfortunately were not funded earlier, so our grant is only 3 years. So we have only 3 years comparing to you in the capital too much, and to achieve the parity for the agency, for the funding agency. So despite of that, we have few successes that we are very proud of. So between the last 3 years, we managed to open and continue to recruit to 42 clinical trials, and 33 of them were regulated and 9 unregulated. We have 15 active principal investigators between different cancer-related disciplines, and then include obviously medical oncology and hematology, but we have also started 2 clinical trials, interventional clinical trials in the palliative medicine, and obviously we are working very closely in quality of life studies, in non-regulated clinical studies. One of the things that we needed to implement to be robust in what we are doing, in the service that we are providing to our patients, is reorganization of the unit. And we are obviously smaller than other centers, and one of the things that helped us, and I will talk about this a little bit later, is reorganization with disease specificity. So in the plain terms, we have developed an expertise with some people to deliver medical oncology focused clinical trials and hematology. And this allowed us to, number 1, retain staff, and number 2, get the rapid accrual of the patients. And specifically because different toxicities and different requirement for the investment and resources between the trials. And so education and disease-specific expertise is one of the things that I think from our perspective was very, very important. So that's how the structure of our unit looks like at the moment. So we have a shared startup manager, we have manager for the unit, we have administration support. However, the nursing coordination and data staff concentrates on different disorders, different disciplines. So hematology, nurses, hematology coordinators, and data are separate. They don't cross-cover unless they have to, obviously, with medical oncology. Another successful story that I think some of you may be aware is because of lack of dedicated funding for rare cancers, we have focus on the development of a trial program for rare cancers, and I will just show you the example of hematology. So for about 2 years, we are able to offer participation in frontline clinical trials for patients with both myeloma and acute myeloid leukemia across the country. So keeping things in the perspective, AML is about 1% of all cancers. Prevalence of AML is only 1%, and myeloma is again 1 to 1.5% of cancers. However, this year is the first year that we'll be able to offer across the country, not in Galway, not in Northwest Hospital Group, but across the country, participation to frontline clinical trial in AML and myeloma for all patients. So we will have saturation of the trials for almost 100%. And what is really important, this effort came as a national effort, and all the hospital groups are participating, and each of those clinical trials will be open in every hospital group. So all the patients, I hope, will be able to participate in those clinical trials. So this is a very significant improvement, because 2 years ago we were able to offer AML trials only to 60% of newly diagnosed patients. So challenges. Obviously, each hospital group, each organization has its own challenges. However, we are a little bit more disadvantaged. And number one, I already mentioned that we have a shorter grant funding cycle, so we need to match with other colleagues much faster than others. We, unfortunately, especially for the rare cancers, we are subject to competition from the bigger countries. And you already saw today that, big four, Germany, France, Spain, Italy, those are the first choices, especially for the rare cancer. So the collaboration between hospital, between Ireland and internationally, I think is the key for the success, for the ability for us to bring the clinical trials to Ireland. The limiting funding, unfortunately, I hope that with the next grant funding that will be the past. We are very challenged with the staff recruitment, and just to give you an example how our local perspective looks like, our startup manager, who is very significant part of our standard process, this post has rotated 3 times within the last 18 months. So it is very, very challenging, because it's like almost we get someone trained to the level of being independent, and the moment that person is gone. So that's very significant. So, and staff retention. So those are the key challenges that I see from the West of Ireland perspective. So our future. My thoughts, and those are my own personal thoughts, is that to allow a significant change in the patient outcome, especially in the rare cancers, it will be very important to work and attract frontline trials, because as you all as a cancer practitioners understand, the first treatment is the best treatment. The help for the patient who has a relapsed disease is much more difficult, and the outcomes are much more difficult to achieve. The second reflection that I have is that I would really like to see the movement from grant-based funding model to the infrastructure-based. That would allow us to maintain the staff, that would allow us to offer them career progression, and will allow us and probably all the other organizations to attract good quality people who would see cancer trials as a career option rather than a temporary contract. Also, I have a few thoughts about the metrics, and the metrics that I see that is required by HRB at the moment, I don't think it reflects the intensity of the trials. And there is a very big difference between the intensity of the frontline interventional clinical trial with, let's say, immunotherapy or cancer or cell immunotherapy versus obviously equally important, but a quality of life or observational study that was listed in this metrics. And until our founders will see the difference, the heavy-duty clinical trials for patients without real other options will be very difficult to bring to Ireland. And just to give you an example, that cell therapy, CAR Ts, were tried initially in 2012, and the first patient in Ireland who was recruited into clinical trial was in 2022. We are 10 years behind, and this is just one of those examples. Another thing that I think the Cancer Trials Ireland could take the lead on is the pathway for inter-unit or inter-hospital group referrals. And I'm not talking about the fact that I can send the patient to Beaumont or James's for a clinical trial, but for a patient from my favorite place, Belmullet, it's not practical because they cannot relocate to Dublin for the purpose, and they cannot travel. So if we developed a pathway, a form of agreement, data sharing agreement, that some of the interventions could be done, for example, in Dublin, but patient could be clinically followed up, reported, and assessed for the toxicity SAEs locally. Until we have it, those patients will never be candidates for clinical trials. And the last thing that actually is very difficult from our perspective is the requirement for the grant to get the institutional host institution co-funding. The hospitals, the public hospitals, don't have dedicated funding for that, and this is going to be a big struggle in the next round of funding if this requirement is maintained. Thank you for your attention.